Uh, I'm impressed that you showed up and came back after the break, knowing that we're going to be talking about death. I really want to emphasize, though, that my focus is on living. It's about living right up to the last breath. And it's about you helping your loved one to live with that last breath in their way so that it's authentic and full. And that's what I'm here to talk about today, how you can help your loved one to die at the end of life. So what I'd really like to do is to begin and ask you to rethink and redesign the end of our lives. And I'd like us to focus on increasing our abilities to provide a meaningful support to our loved ones as they face the end of life. And really this segues so nicely with Daniel's talk, because what I'm asking is that you all become palliative agents. Not necessarily with the medical information and background, but with the emotional and spiritual focus that palliative care does provide. I come to this story from my own experience, from my own wound, really, and it's why I care so deeply about this work. I was not able to help my mother die. I was 13. She had an illness, but in my family, as is common in many, many families, we did not talk about her illness. I did not have the vocabulary. I certainly didn't have the skills or information at 13, and I did not have the emotional support. So one day, she was there. She was ill. I did the only thing that I knew to do, which was to take my two younger brothers to the beach so she could sleep, thinking that she just had the flu. And when I came back that afternoon, her bed was empty. I was not able to help her in my mind. I did not say goodbye. My mother died in surgery, and I lived for years afterward without information, because my father, with all the best intentions, felt that he was protecting us by not talking about her illness. But I had no information at 13 about how she died, why she died, where she died. And so in the absence of that information, I made up my own. I filled in the hole. And the hole was filled with real misinformation and misinterpretation, because I told myself that my mother had died because her only daughter didn't even tell her that she loved her. And so my mother didn't fight hard enough to stay alive because she thought I didn't love her. And I lived for years and years with that sense of remorse and guilt that exacerbated my grief. It was a tragedy. That lack of information, that lack of intervention and emotional support changed my grief. And so I vowed that I would never let that happen again. I would never be absent from another loved one's death. And I spent the rest of my life preparing so that that would not happen. And I took myself to school, and I studied thanatology, which is the study of death and dying. And I worked in 9 hospices across the United States, learning from very courageous patients who taught me what they needed so that I could then pass that on. And sure enough, I was teaching death and dying and had a private practice in Virginia when my father, 13 years ago, called me and said, Lani, it wasn't pneumonia, but they found that it's end-stage lung cancer. And I had prepared all my life for this. And so I told my husband, see ya, I hope I'll be gone for 6 months. And I went home to Hawaii. I came back to be my father's primary caregiver. I moved in with him. I signed up with hospice for him. And I did everything that these patients had taught me to do. And I'm here to give you a model and just suggestions, because of course everyone is unique and has unique needs, and I'm really here to advocate for everyone's unique, authentic death. But I want to just give you a story of how I did it with my dad. So I moved in, and I was very direct, and I said the word death and dying. I put it all on the table. I had a family meeting with my brothers and in-laws, and I asked Dad, what do you want? You may have 6 months, you may have 6 weeks. We made a bucket list for him. Dad, if you had just 6 weeks or 6 days, how do you want to spend your time? And we wrote it down. I touched him because, boy, that's what the dying have taught me. They want to be touched. We had routines of real physical closeness and storytelling. Dad and I wrote his obituary together, and I'm so glad we did that, because in the storytelling of who he was and the stories of his life, I learned so much about him, and I thought I knew him better than anybody in the world. But I learned so much about him, and we wrote his obituary. He got to be the author of his life. And I would have had it wrong. There would have been so many pukas in that story about him. But because we had talked story, he got to have it his way. And I asked very specific questions such as, Dad, where do you want to be when you die? Who do you want to be with you? Who do you not want to be in the room? An equally valid question. What do you want to be smelling? What do you want to be seeing? What would you like to be listening to? As many details as we could, so we could really design his perfect death. We had a ritual every night, and I used to massage oil into his very thin, papery skin, and we kind of would spread his arms so that he could get just a little more air in his lungs. I would put on a clean undershirt, tuck him into bed. And on this one night, I tucked him into bed and I kissed his forehead and I said, Dad, you are the light of my life. And he said, oh, I'm glad I'm the light of yours because I sure ain't the light of mine. And that was the last thing he said. He went to bed that night, and the next morning I got up again with my ritual of going into him. And he pulled out the oxygen. And I knew him so well, and we had rehearsed so many scenarios that I said, Dad, do you want the oxygen? No more, he said. I said, do you want me to turn the oxygen off? And he said, yes. And I said, you understand that you won't last long? And he said, yes. So I turned off the oxygen, and I came back and crawled into bed with him. I held him in my arms. I had the music on that he asked for. I had the plumeria blossoms on the side of the dresser right next to his bed. I held him and I stroked him gently, and I breathed with him very slowly. I said the only things that are important at the end of life, which are I love you and thank you, and it's okay. We'll all be okay. You can go. His eyes were closed for about a half an hour. And all of a sudden, he opened his eyes and looked in the corner of the room and said my mother's nickname. And I said to him, it's okay, Dad. Of course she's here. Go to her. And he took his last breath. I give you that story as a good death because he designed that and he got it and I gave it to him. And being able to give him that palliative care, that companionship, attending to his values and his wishes, changed my grief. I did not grieve as I had for my mother. I had no remorse. I was so full of gratitude. I knew I had given him a gift, and I knew that he had given me a gift that healed the past. So the takeaway is that you too can make a difference at the end of your loved one's life. It's rare for us to create the opportunities or to initiate conversations about the end of life. And in fact, I think there was just a Stanford study that showed that 99.9% of physicians are not comfortable initiating that conversation, Dr. Fishburne being the exception. But I have been invited into homes over and over, especially from adult children who know that their parents need to have that conversation, but they don't, as adult children, know how to start that. And usually when I ask them, what's that about, they'll say they're really afraid that they don't want mom or dad to think that by bringing up this conversation, they really are saying that they move along. It's time to die. So there are ways that we can initiate that conversation, and I usually use myself. I go in and I'll speak with Tutu and I'll say, I've been thinking lately about how I want to die at the end of life. And I know that I want to write it down. And I also know that even as important as it is to write it down, I must communicate it face to face with those that I'm asking to follow my wishes. But I'm wondering, Tutu, what you care about at the end of your life. So we just invite them into that conversation, and maybe you can begin and use yourself. So what I want to leave you with today is just the concept of participation, that we can learn how to participate at the end of life to be there for the one we love. I'm not asking you to do it all. I'm not asking you to do it all right. The goal isn't to know it all. The challenge is, and there's a posture to this, the challenge is to lean in close to death, because what the dying experience is usually this. People want to distance themselves from the subject, the illness, or the process. So I'm asking you to get close, and I'm telling you that you can't do it wrong unless you don't do it. Just do something your way. What's your good death? What's important to you? If you had a choice, if you could make that choice, would you be at home? Would you be in the hospital? Might you want to die alone? Or do you want to be surrounded by loved ones or a pet? The end result when we attend to these details and when we participate is that our loved one has more dignity. They feel greater intimacy and greater peace at the end. They benefit. And if you participate, I promise you that your grief will be softer, you will move through it more rapidly, less intensely. And thirdly, when we participate, we model compassion and caring for the next generation. We pass it on. That becomes our legacy to our children and our grandchildren. We show them what caring and compassion looks like. So I want to talk about what a good death is. And as I'm talking about this, I'd like you to be thinking about good deaths that perhaps you have witnessed or participated with, but also what's your good death? What are your wishes? I want to tell you what the dying have taught me about what they need. And I want to give you some strategies that you can take home so that you can actually act and behave in a palliative way. So I gave you some homework, and knowing Virginia, I bet you all did it. That death self-efficacy scale is a tool that I use when I'm training healthcare professionals or volunteers working with end of life. These are behaviors that show us where you're comfortable or less comfortable around issues of death and dying. And if you practice these behaviors, you will see that your confidence is raised and a sense of competency is raised. It's always surprising to me that many 30-year-olds have never been to a funeral. They've never been in the room of a dying person. But as we have these experiences, we have less and less fear and anxiety. What we learn, what we're able to say to ourselves is, I can handle it. I can cope. And not being able to say that to ourselves is one of the biggest reasons why people don't participate. Just that belief that I can't handle it. So if you look over this scale, I wonder if anyone would share with me if they had an insight or if they learned where they're least comfortable, because then maybe I can address that with a strategy. Where did you find your discomfort? Anybody? Yes, that's a great one. So allowing a family or client or patient to support you. So now I'm going to say that you all are ministering to a loved one who's dying. And we think we're helping them. That is usually a position of power. And when it's turned around, and we do need help and support ourselves as caregivers, yes, we are exhausted, we are stressed, we are emotionally burned out, perhaps. There are family dynamics that are all over the map. As caregivers, we need a lot of support. For that patient to turn around and want to support us can be very challenging because we feel vulnerable or we might feel weaker. It's good to know how the patient might feel. So learning to be in a position of vulnerability is really an exercise in learning to be equal. When I train, I'm going to try this, because I'm going to walk. Can you hear me? Yep. So when I'm training hospice patients, I really like to make a distinction between helping and being of service. This isn't my idea. This is Rachel Naomi Rieman's idea, concept of when we help someone. Kenneth, may I borrow you? When I help someone, this is the posture of helping. Who's above? Who's below? Who's in power? Right. When I am in service to someone, this is my posture. We are equals. We both have something to teach and to share with each other. And this is the position that I want to offer palliative care and my emotional support from. So one of the techniques that you can do is when your loved one is in a hospital or even at home and someone comes in to visit, the doctor comes in for a visit and they're standing over your loved one, invite them to sit down and be at equal eye distance with them. Here's another difference between helping and support. So James, may I borrow you? Okay. When I come to the bedside of James, and first of all, if I come into James's room, James is feeling as though he's locked in a bed. He can't get out. I don't want to impose myself or make him even more of a prisoner, so I want to ask permission. James, would this be a good time to visit? Would you like a visit right now? Thank you. And then I'm going to enter. Many people do not ask permission. And then I'm going to ask permission, and I know James. We have a relationship. James, would it be okay if I held your hand? Surely. Okay. Again, if I don't ask permission, who's got the power? Okay. When I go to hold James' hand, if his hand is on the bed and I'm holding it like this, who's in power? It's really hard for James to tactfully remove his hand. But if I put my hand under James, then he can remove it whenever he wants. Very subtle distinction, but I want to give my loved one as much control as power as can happen, okay? And when we're ill and vulnerable, that's one of the first things that we feel is that we just don't have any power or independence. So a distinction between helping and being of service, a posture, a way of being with them that's different. One of the things that gets in our way of being in service is our myths and the way that we think. So let me just throw out some ways that we think everybody thinks. How about this? Hospice means giving up. Daniel did a good job of making the distinction, but really we have a lot of concern about, I don't want to call in hospice, or I hear this a lot, don't tell my loved one that we've signed him up for hospice. Don't use the H word. Hospice is not about giving up hope. It is about reframing and finding new hope. So while we may not have hope for a treatment for cure any longer, here's what we hope for now. And I'll use the words. What we hope for and we're going to design for is intimacy at the end of life. Really telling that truth. Really sharing at our deepest level who we are. Connection. Finishing that business that maybe we had been so disconnected for so long. How about the concept? How about the myth that death is a tragedy? Let me show you another example of being with a patient who didn't see death as a tragedy at all. In fact, at the end of his life, he was saying to me, I'm all full up. I'm good to go. That's a man who did not see his death as a tragedy. That person who had all of his family around for the first time in 30 years, people finally saying, I love you, you matter. That's not a tragedy. That's an opportunity. Or the myth that I can't go to their hospital room because I don't know what to say. I want you all have been successful, and there are a lot of strengths and competencies that have gotten you right where you are. And it's those same strengths and competencies that you will apply and take in as you work with your loved one. What are your strengths? And I don't know what to say. You know what the greatest medicine is? Touch and listen. Touch and listen. So our goal is to make dying safe, to make it peaceful. What does that look like for your loved one? Let's ask them. I want them to feel companioned. I'll go right up to the end with you, is what I'm communicating with my presence, with my eye contact, with my voice, with the way I consistently show up. You will be companioned to the end, because that's what matters the most to them. Death has a potential of being so full of meaning instead of tragedy when we put it in the context of relationships. So here's what the dying tell me that they fear the most. It is not their imminent death. It is not the approaching grim reaper. What they fear the most, over and over, what I hear in different ways, is that they fear being emotionally abandoned. And why not? Because they feel diseased, they feel untouchable, they feel ugly, they feel vulnerable, they feel weak, they feel like they are no longer themselves, and they feel as though they're a burden. So knowing that, I want to attend to those fears. I want to let them know that right up to the end, Dad, you're the light of my life. That's what I see. I don't see a little shriveled 80-pound body. I see the light. They do fear being in pain, physical pain, but we've addressed that with palliative care. They fear becoming dependent, of losing their dignity and their independence. So you can help them with that advance directive so that they are in charge. They're making choices. They fear being untouchable. So what do we do about that? Well, we touch them. We touch them. We stay close. We look them in the eye. We connect in so many different ways. We remember who they always were, and we tell them. and we tell them honestly. I had real bad skin cancer many years ago, and I'm going to tell on my husband, but I had real bad skin cancer, and I had a treatment that made me look like an iguana, I kid you not, with real thick scabs all over my face. And one day I looked in the mirror, and I was just in tears, and I said to my husband, "Oh, I am so ugly." And he said, "Oh, no, you're not. No, you're not." And my whole body went stiff because I knew he was lying. And if he was lying about that, what else had he been lying about? So I tried on the second day. Oh, God, I'm just despicable. No, you're not. No, you're not. And on the third day, he got it. Yes, your face looks really mess. But this too shall pass, and it's not who I see. So I want to be with them honestly, and when they ask for feedback, when they ask for an honest response, I want to be there. The dying fear being isolated. Again, we have an answer for that, don't we? Be with them, companion them, show up when you say you're going to, bring in their loved ones, finish business. A good death is as unique as the individual, but it relates to all of those needs that they've been telling me about. We can give them a sense of control and honor their values and wishes, but we have to know what they are. So we have to start that conversation. You can do that. Ask them the curious, open-ended questions. Just wonder with them. Dad, I wonder what the best day of your life was. I wonder how we could do that now. I wonder what you care about if you only had a week left. I wonder if you'd rather be cremated or buried. I wonder what your obituary ought to say. I have a mantra that we all get one death, one life and one death. And I am vigilant about making it their way. So in my family, if there was ever actually there weren't disagreements because right up front, I put out the mantra, what would Dad want? What would Dad want? As a caregiver, it was not my agenda. My wishes were not important. It was Dad's wishes because it was his death. I'm going to set up my death my way. I get that vote, but my dad got his vote. So again, if you could visualize, if you could make those choices, what would your best death be? Where? Who? What are you seeing? What are you listening to? And how can you put that into motion? So, how can you make a difference? Your presence is so powerful. Your silent presence. When you listen from the heart instead of the head. And a concept that I use a lot is that I really try to delete my need to understand what the patient is saying. Rather, I want to accept. Because, for example, someone says to you, a loved one says to you that it's against your family culture, background, or experience. They want to be cremated instead of buried. You don't understand why they would make that decision. That's less important than you accepting their decision. Accepting looks like this. And that, too, is a posture of presence. What I do best with a patient, with a loved one, is act as a container. I hold their experience, and oftentimes I'll do that with a patient. Give me your experience. Share your pain. Let's have some respite from this for a moment. I'll hold it, and I'll give it back to you whenever you want it. Let me hold it with you. Okay? We listen without answers. We listen without advice. We listen without really sharing our experience unless it's asked for. So, I know we've all been in the hospital and had a procedure for something. And that well-meaning volunteer comes and stands at the door when you're exhausted for 30 minutes and tells you about the same operation that she's had. No, not comforting. But being with the patient, and there are many ways to be with the patient, just eye to eye, if they are not comfortable with touch. I want to respect that. Being the container, paying attention to the nonverbals, because of course we know that only 7% of communication is verbal. I communicate much more through my presence, my body language, the tone of my voice. So I want to be very careful about how I speak with someone, especially at the end of life. I want to be an added value to the serenity of that room. I want to take care of their physical needs, of course, by giving them comfort, a fresh nightshirt, fresh linens, surroundings, and again, asking them what they need. And the practical needs. If a mother is dying, one of the first practical needs I want to ask about is what she needs me to do for her children. What needs to be done around financial needs? In other words, how can we set aside all of those anxieties and fears that the patient has? How can we take care of them for them? We want to attend to the emotional and spiritual needs and allow all emotions, because of course when we are ill and on the roller coaster ride of illness, we are up and down, we are angry, we are disappointed, we have angst at God. So I want to allow for everything without judgment and without comparison. So if you had mom die last year and she did it in her way and she was just pleasant as punch, and you're now tending to dad, and he's a cantankerous old guy, and that's the way he was all of his life. Let's let him go out that way, but without judgment that he should be doing it the way mom did it. What it sounds like, what does present sound like? Language around this sounds like, Dad, I've got your back. Dad, I'm going to be here as long and as close as you need me. You're the boss. No matter how hard it gets, I'll be by your side. That's what presence and caring sounds like. Some of the other techniques and things that we can do around emotional needs, I mentioned a scrapbook, to review the person's life through a scrapbook, a life review, really finding a legacy and being able to articulate that and put that into words. What will your grandchildren have of you? What will they know of you? What are you passing on? How will you be remembered? The dying tell me that they need you to listen to their stories 100 times, and I'm talking about the same story. And that's important because that one story that they keep repeating over and over, that's the pivotal point of their life. That's where they find the meaning of their life. That's why they were here. But most people respond to that same story by saying, you told me that before. And that's where I want to bring in grandchildren who want to hear that story over and over and over again. And that's how you can get that next generation to participate in a really lovely, meaningful way. So listen to their stories over and over because you're really helping them to wrap up their life. Open up the conversation. One of the best questions that I ask, and I can ask it every single day, is, today, what's the hardest thing? It's a great way that you can speak about what's really going on for them when very few other people want to. They want to dance around the subject. They only want to talk about the nice things. But really what's happening to them is the hardest thing. And they want someone to listen, to process it with. So today, what's the hardest thing? Tomorrow, what's the hardest thing? It often changes. Or another question, what would you need to happen to feel at peace? And there you find about reconciling and mending old relationships, and you can help with that. but you want to attend to their fears. You want to validate their journey. And now I'm going to tell the story about validating a journey, because I get called into a lot of homes when people don't know how to respond to their dying kupuna who keep talking about an invisible presence in the room. So I go in and I sit down, and he says to me, the patient says to me, "Do you see him in the corner of the room?" And I look in the corner of the room and I say, "No, I don't see him." Honesty. He says, "Well, he's in the corner of the room." I said, "I believe you." The patient says, "Well, why can't you see him?" And I say, "Because I don't think he came for me. I think he wants you to see him." And I'll continue on with the conversation because it is meaningful to him. Is he saying something to you? Why do you think he's here? And what you'll get back is that usually, very commonly, it is a predeceased loved one, not necessarily family, but a friend, an old fishing buddy that has come back to take him on. And it's of great comfort. Why would we want to dismiss that? Those are not hallucinations. There's nothing painful or scary about those. They want to talk about them. So we want to be present for their experience. And again, can I understand that? No. Can I accept it? Yes. Does it make a difference? Yes. So let him tell this story. Additionally, a few techniques that I just want to mention. And if I had a long time, I'd have you all on the floor in partners. And to teach you a technique called the ah breath. So for people that I'm working with who are not comfortable with touch, or maybe their eyes are not open and I can't connect eye to eye, I can still communicate with them the most important message. What's the most important message? I am here. You are not alone. And I do that through the sound of my breath. It's called the ah breath. It's an old Buddhist meditation. When my father's eyes were closed and I had him in my arms, there was nothing left to say, but I wanted him to know that I was there, and so I followed his breath. And all it sounded like was, ah, ah, very gently right next to his ear. But I was following his breath, and at the end of life, when there's long spans between breaths, that's hard work. That's hard work. I'm not thinking about my shopping list. I'm not thinking about my own pain. I am totally focused on the other person, and it is a great comfort. And all I'm saying with my breath is, I am here, I am here, I am here. So that's the ah breath. Don't forget about music therapy. If you have a loved one who has Alzheimer's, here's a great scenario. You have a young son, isn't comfortable going to see grandma, isn't comfortable touching or even saying goodbye to her, but he's an IT whiz. He wants to do something for grandma, but he doesn't know what. So you say to him, let's make a CD of all the oldies but goodies from the time grandma was 10 years old up until the present. And you play that for her, whether she's with it or not. And there has been really amazing research that people perk up around that. Also, music therapy, I have my own CD, my own death disc of music that I want to go out with. You can do that now for yourselves. What's music that makes you feel peaceful? What's music that soothes you? What is music that relaxes you? You can do that for your loved one. You can do that for yourself. Don't forget about touch with children. I want to invite young children in to massage Tutu's hand, to comb her hair, again, just to participate. Daniel talked a lot about the end-of-life conversations. I just want to tell you that making the decision is really important. Knowing your own values and wishes, absolutely first. Writing it down, absolutely important. Doesn't do a damn bit of good if it's locked in a drawer and you haven't told anybody where it is. Okay? So you need to have that face-to-face conversation. so that people really understand what you want, but also tell them why you want. Like Daniel wrote the letter about his philosophy. That Stanford letter is a great tool to use, and I highly encourage it. I think that's what I want to say. I want to hear your questions and what you care about, what I can answer.